Performance improvement and peer review. What is performance improvement, or PI? It is the continuous evaluation of a trauma system and trauma providers through structured review of the process of care as well as the outcome. It is also a realization that conditions exist in structures and/or processes of care where modification could reduce the incidence of real or potentially adverse events or, ideally, improve the outcomes. You should always ask the question, if the same patient were to walk through the door today, would we do anything differently? Performance improvement is dynamic yet prescriptive, multidisciplinary, individualized to your facility, and integrated into the hospital's PI system. Performance improvement is the #1 reason hospitals fail trauma center designation. Yep, it's that important. PI allows evaluation of patient care outcomes, provider response, and system performance. It improves patient care at the bedside level. It fosters competent and accountable providers. It allows for organized events that focus on opportunities for improvement. It is at the core of trauma center development and maturation. It evaluates cost of care and improves the fiscal side of a trauma program. Consider these things about PI. Nobody has an ideal trauma program. Most programs struggle with PI. No precise prescription for PI exists. The trauma surgeon and TMD must lead. The effort must be multidisciplinary. The trauma PI program can set the tone for PI in the whole facility. Adverse outcomes do not always indicate bad care. The focus should be on opportunities for improvement rather than on problems. Most errors are related to system failure, not provider care. Timely collection and analysis of meaningful data are great challenges. A solid PI program provides leverage for obtaining needed resources. Trauma PI is most effective when integrated with hospital-wide PI, and the trauma program should be familiar with national initiatives for patient safety. Here we lay out the steps or components of trauma PI, starting with identify the trauma patient, review the data, identify the issue, pursue additional levels of review as required, formulate conclusions, create an action plan, implement the action plan, and if the action plan worked, your event is resolved and the loop is closed. What is the trauma medical director's role in this process? They are responsible for the leadership of a trauma PI program. They frequently delegate trauma PI responsibilities to other team members, but retain ultimate accountability, which should be reflected in the job description. They direct the peer review process and oversee the multidisciplinary review process, and they actively participate in the hospital-wide PI program. Let's go through more roles and responsibilities. Trauma medical directors have authority to direct the PI plan. They direct development of evidence-based practice guidelines. They select cases for PI committees and referrals, and perform the second level of review prior to peer review. They provide mitigation and prevention plan input, elevate concerns to medical staff peer review, and analyze PI trends and physician profiles. They direct PI correspondence, lead peer review discussions, and moderate peer review determinations and judgments. They follow up with provider-related counseling and with trauma privilege issues. They also make sure there is a process in place to disseminate key information to absent members with documentation. Disseminating key information is very important for designation and verification. They must be able to show how issues and trends are communicated to providers that are not present. Here's the trauma coordinator roles and responsibilities. TCs fill clinical, administrative, and quality review functions. They are heavily involved in trauma PI and share responsibility with the trauma medical director for collecting and presenting data to the various PI committees. They may also fill the trauma registrar role. They direct implementation of the PI plan, define tools and processes, coordinate various PI committee meetings, participate in peer review discussions and meetings, are responsible for meeting minutes, do PI through trauma continuum, ensures validation of registry data, participates in operationalizing practice guidelines, facilitates resolution and loop closure, represents trauma program on hospital and system committees, and manages follow-up on PI system issues and peer review issues. There are 2 required types of trauma committees and 1 optional type. The structure of these is defined by ACS and state regulations and based on trauma level and volume. The required committees are the Trauma Peer Review Committee, which is involved with clinical concerns at the patient level and provider level events, and the Multidisciplinary Trauma Committee, which deals with operation events and is process and system focused. The optional committees are pre-hospital PI and morbidity and mortality review. These optional committees may be integrated into the required committees. The goals of the committees are to develop a culture that promotes both system and patient care improvements and aligns with national standards, review performance and patient safety of the trauma center, present factual, objective data and processes to facilitate decision-making by the committee, include representatives from all phases of care with attendance recorded. Other committee members have the following responsibilities: creating a structured orientation to the PI plan and process, having awareness of defined event reviews, complications definitions, and defined judgment or review determination language, reporting identified events and occurrences to the trauma team, shared responsibility regarding extensive review for cases going to a PI meeting, participating in peer review discussion and determinations, participating in developing corrective action plans, and giving routine feedback. Let's dig deeper into the Trauma Peer Review Committee. The goal of this committee is to review the efficacy, efficiency, and safety of trauma patient care, systematically reviewing mortalities, significant complications, and process variances associated with unanticipated outcomes, and determining opportunities for improvement. Many facilities struggle with this concept and requirement. Remember, system events are not provider specific. Here's a list of tasks that take place within this committee that the TMD leads. So what cases do we need to peer review? All trauma deaths, select occurrences, sentinel events, problem trends, unusual or uncommon cases, unexpected outcomes, and great saves. And for those that don't know the term, a sentinel event is an unexpected occurrence involving death or serious physical or psychological injury or the risk thereof. Serious injury specifically includes loss of limb or function. Peer review committee meetings can occur as a standalone meeting, at the same time as a medical staff peer review with a separate agenda and minutes, at the time of a multidisciplinary trauma committee meeting, or via teleconference. Let's discuss some peer review obstacles. Not enough providers to perform peer review, absence of required attendees, imperfect probability of survival scoring, incomplete data for case discussion, absence of autopsy or death information, inadequate minutes reflecting the critical discussion of the events, or lack of reporting trends and issues identified to the PI committee. Now we'll move to the Multidisciplinary Trauma Committee. The committee consists of the trauma medical director, trauma coordinator, and representatives may include surgery, OR, ED and rehab, lab, radiology, pre-hospital, social services, and administration. Characteristics and responsibilities are below. Address operational and infrastructure events, verification and designation readiness, system and operations focused, pre-hospital processes discussed, transfers and diversions, it's data driven, process focused, and systems events referred by peer review. Multidisciplinary trauma committees require documentation of the following: minutes reflecting attendance and actions of multidisciplinary committees, use of audit filters or specific indicators to monitor performance, use of trauma registry to monitor performance, classification of deaths and complications, trauma deaths automatically included in PI review, identified injuries, identified opportunities for improvement, identified comorbid conditions. Identify comorbid conditions that may have played a role in the patient's demise, such as use of anticoagulants or bleeding conditions, morbid obesity, extremes of age, pregnancy, heart or lung disease, etc. Also note that it's important to identify the method of obtaining autopsy results in a timely manner. This is often included in the medical record, but may not be timely enough to be included in your PI review. Autopsies may be obtained through a relationship developed with the county coroner or pathologist. Additionally, documentation needs to be included that determines the preventability of the death. Mortality without opportunity for improvement was non-preventable. Anticipated mortality with opportunity for improvement was potentially preventable. Unanticipated mortality with opportunity for improvement was preventable. Even with a non-preventable death, opportunities for improvement in care can be identified. What tools do we use for tracking? There are trauma standards of care that are evidence-based and built on national, regional, and local standards of care. Outside of those, there are trauma audit filters. These assist with monitoring the process of care relative to the standards of care. These are flags to look for that will prompt a review. This does not imply that bad care occurred, and not all of these flags require routine review. Audit filters are like a big net. You cast it far and wide to catch everything, but some gets thrown out. For example, you notice that the EMS scene time was greater than 20 minutes. After a review of care, it was determined that that was because of a long extrication time. This wouldn't require further review and does not imply bad care. It was justified. Let's talk more about audit filters. Audit filters are a mechanism for improving quality of care and are defined as specific clinical processes or outcomes of care that, when they occur, may represent unfavorable deviations from an established norm. They warrant prompt review and feedback. Audit filters need to be clearly defined with definitions based on accepted standards of care and practice. They should be valuable to your program and facility. They need to be incorporated into the Trauma PI written plan and reviewed at least annually. And they include regional RTAC indicators and potentially state STCC indicators. A trauma audit review occurs for two reasons. One, being simply the frequency of trauma cases or specific events, or two, when based on case reviews. These are case reviews where an audit filter was triggered or when a specific population needs to be looked at. Let's look at some examples of audit filters. There are process-related audit filters, which include checks for complete documentation, evidence of over or under triage, organ donation rates, and emergency department dwell time. Here are some examples of quality indicator audit filters, like missing EMS reports, open fractures that are taken to the OR after more than 8 hours, missed injuries, and delayed diagnoses. Each quality indicator is a statement of an ideal expectation. Cases are identified through the registry over a period of time. Many valid reasons may exist as to why this option may not have been appropriate or possible. Besides audit filters, let's look at the trauma standards of care criteria. These include any deaths, the length of stay, patients who experience shock, patient and family satisfaction, and hospital charges. There are also specific pediatric measures to look out for. Case reviews are needed if any of the following occur, including head injuries, non-accidental trauma, and delays in transfer. Regional trauma committees can decide on very specific criteria to trigger case reviews. The next 3 slides show these current 2021 criteria for Western RTAC, Central RTAC, and Eastern RTAC. The State Trauma Care Committee also generates specific criteria for case review. These are listed here. Let's review the components of Trauma PI we brought up earlier. Step 1. These are the patients that should be entered into the PI process. Patients meeting criteria for entry into the statewide trauma registry, trauma registry inclusion criteria, patients that meet injury codes and must include one of the following: death resulting from traumatic injury, patient transfer from one acute care hospital to another acute care hospital, patients who were an inpatient or observed patient for trauma, and patients with injury 14 days prior to admission. Step 2 is efficient data collection. Data collected needs to be easily obtainable, clinically relevant, clearly defined, and limited in scope. It is important to remember that we cannot monitor and fix every problem in the trauma program. In fact, a comprehensive review of the program may be too ambitious. Usually, a more focused approach is prioritized using the quality of data elements. As mentioned previously, no precise prescription for this effort exists. Be creative in using your resources to improve care by integrating efforts with hospital-wide PI programs. Frequently, a distinction is made between concurrent data collection and retrospective data abstraction. The concurrent implies that data is recorded in real time as care is provided. For example, immediate or near immediate recording of the events of care. Retrospective implies abstraction from charts, conferences, or registry reports often analyzed days, weeks, months, or even years after care. The implication is that concurrent data is more accurate and therefore more useful. However, the labor-intensive nature of concurrent data acquisition may limit the value and completeness of the information. When collecting data, there are many sources it can come from. Here are some examples, including EMS, daily rounds, conferences, hallway conversations, autopsies, and registry data. As you go through this data, compare what you find to the standards of care, the review rules put out by the STCC and RTAC, and any audit filters. Look for issues. Identifying issues is step 3 of the process. One of the goals of the Montana Trauma System is for trauma program staff at the transferring hospital to receive adequate and timely written feedback from the trauma program at the regional trauma centers. As the trauma system continues its development, this same feedback is being requested from the area trauma centers where trauma patients have been transferred to. This feedback is a summary of injuries identified and care provided. Performance issues might include time at facility prior to transfer, need for chest tube at receiving facility, need for intubation, and inappropriate splinting or cervical spine stabilization. These are filters that flag cases for review, but not a judgment of care. They identify cases for closer review only and are meant to be helpful. Performance improvement issue identification is also facilitated through trauma registry feedback provided by the Montana Department of Public Health and Human Services, EMS, and Trauma Systems section. If you provide data to the state from the web-based form, you will receive a letter back with each batch of records which identifies some opportunities you may consider for PI. Because of the limited information provided to the state, the facility might also be internally monitoring for PI issues as well. Summary reports are provided at 2 of the RTAC meetings each year. Facility-specific summary reports are provided annually. At this point in the process, you've identified issues and now the cases need to be reviewed. These reviews have different levels and represent step 4 in the PI process. There are primary, secondary, tertiary, and quaternary review levels that involve different individuals' contribution. Note that the PI loop closure can happen at any of these levels depending on the issue. We'll discuss loop closure and what happens after review in a few slides. Right now, let's dive into the levels of review. We start with the primary review. This is done by the trauma coordinator. This is where issues are first discovered. The event is confirmed, and if immediately resolved, the loop can be closed. Make sure that you have an electronic PI tracking system to show that if the event was addressed, what actions were taken, and that it was closed. Determine if it needs more review. If the event needs more review, it is brought to the trauma medical director for the secondary review. All individuals involved are confirmed, and a timeline is developed. It is reviewed closely by both TC and TMD. It is possible to resolve the issue and close the loop here. If not, the event may require referral to committee or other personnel. As with the primary review, make sure that a secondary review is tracked in an electronic PI tracking system. Tertiary review utilizes a group of people to review the event. These can be reviewed at formal committee meetings. As a group, the case is evaluated for efficacy, efficiency, and safety of care. It is determined if the issue is a system issue or a provider error. Peer review occurs and any contributing factors are identified. Corrective recommendations and actions are decided on. The loop can be closed, and as always, the status process should be tracked. Quaternary review is the next level of case review. This is an external review that takes place via a hospital quality committee or an external peer review group like RTAC or STCC. This slide shows a flow chart of the 4 different levels of review and potential actions that can be taken to address the adverse event. After case review, at whatever level, conclusions need to be drawn and the case needs to be evaluated. This is step 5. What led to the adverse event occurring? These questions here are good examples for digging into the case and determining what corrective action needs to be taken to improve care moving forward. Developing the corrective action plan is the next step and is step 6 in the process. Action plans need to follow the SMART model, meaning they are specific, measurable, attainable, realistic, and timely. Identify opportunities for improvement using supporting data to develop your action plan. With an action plan developed, it's time to implement it, which is step 7. Here are some examples of action plans, including education, review of guidelines and protocols, and system enhancements. Counseling is an option too, which would be delivered by the trauma director, section chief, or administrator. Whatever route you go, make sure that your action plan is well documented so it can be tracked. This brings us to the last step, step 8. Evaluation of the action plan is required to see if the efforts led to the desired outcome. This is why action plans need to be measurable. Ask if the event was resolved, if any barriers were encountered, what an appropriate time frame for the desired goal is, who determines if the event was resolved, and how best should the event resolution be reported. If the action plan was successful and the event has been resolved, the loop can be closed. Some process loops may never be fully closed or complete, but all trauma programs should demonstrate continuous pursuit of performance improvement and patient safety with the system. Systematic use of defined PI process can demonstrate improvement, but more importantly, PI improves patient care. The last part of Step 8's loop closure is monitoring. Action plan effectiveness is determined by monitoring. This includes ensuring the contributing factors that led to the event have been appropriately corrected and the corrective measures taken to prevent and mitigate adverse events are effective. When should you stop monitoring after the desired outcome is reached? Have realistic timeframes for monitoring. Reanalyze PI data periodically to ensure your actions are sustainable. Monitor for repeated events and trend the data along with compliance rates. So let's talk about what happens if your action plan wasn't successful and you can't close the loop. Some reasons for this include provider performance not changing, no improved patient outcomes, and competing priorities. In this case, reevaluate the data and create a new action plan to implement. Seek assistance from peers and supervisors, and consider disciplinary action if the issue is at the provider level. Throughout the PI process that we covered, we keep mentioning a PI record. This is very important. The information that needs to be in this record is a case summary, registry data, correspondence regarding event or care, meeting minutes, confidentiality statements, issue identification, analysis of the concern or trend, corrective actions, supporting PI documents, occurrence tracking, follow-up documentation, and notice of loop closure. That was a lot of information. We'd like to give you time now for a practice session with a case review. Please proceed to the next section in this module, which is a folder that contains a 2-page Excel spreadsheet trauma PI form and a Word document with ED and EMS record information. Review the records and fill out the trauma PI forms. Note that there are many types of PI forms, and these are just examples. When you're done, proceed to the next video in the module.